We're recording today on Ghana country, and I want to acknowledge the traditional owners of this land, the elders past and present, and any Aboriginal and Torres Strait Islander among us.
The curriculum walks through the door, if you like, and you learn all of the scope that you need for your exams at the same time. The wellbeing of students in longitudinal integrated placement seems to be better than the wellbeing of students on block rotation. The advantage of rural communities and rural health services is
Welcome back, everyone. Imagine you're doing a shift, alone, somewhere hours away from the nearest hospital. A patient walks into the clinic needing something you've done maybe twice in your life, under supervision decades ago. There's no one else there with you. What do? We usually learn not to work outside our scope, but what if the patient requires you to? In rural medicine, sometimes you have to. Our guest today has spent her career on exactly that problem, and she gave it a name: clinical courage. Professor Lucie Walters is a rural generalist who works in Mount Gambier in South Australia. That might mean general practice, emergency medicine, inpatient care, and more recently also having worked in Aboriginal health. She's also the director of the Adelaide Rural Clinical School and has researched longitudinal integrated clerkships. Lucie, welcome.
Thank you, it's lovely to be here.
Lucie, you've been a rural generalist in Mount Gambier since 1993. That's longer than I have been alive. What made you stay?
So Mount Gambier was a decision that my husband and I made together. We sat down with a map of Australia and we said, where do we want to live? We wanted a community that we would make our home for our lifetime. We wanted a community which had more than 3 GP obstetricians, so that I would be doing less than 1 in 3 on calls for my life. We wanted somewhere there was 2 high schools, so that if we had children, and we now have children who are in their late 20s, they would go to a school differently to the one that my husband worked as a teacher. And we wanted somewhere where we could be near the sea, near lovely vineyards and near flat water so we could water ski. And so Mount Gambier met those requirements for us.
Perfect. And you are a rural generalist. So what does that mean? Is it different than a general practitioner working in a rural area?
Sure. So in Australia, there's a formal definition that was agreed upon in the Colin Grove Agreement that Professor Paul Worley negotiated with the colleges of general practice and rural medicine. And it describes a rural generalist as someone who works in primary care, who also works providing emergency services or critical care to their community, and then brings a special skill to the group of rural generalists that work in that community that benefits the whole community. So for many years I worked in obstetrics and more recently worked in Aboriginal health in that role.
So you work together and you bring new skill sets to a group of people, but it is very much that you can work outside of the scope of a traditional general practitioner, that you might actually need to play the role of an anesthesiologist or an obstetrician. Certainly.
So obviously I have not done, I haven't ever trained as an anaesthetist, so I wouldn't do anaesthetics. But where I've got special skills, I would work in that area. So for example, previously in obstetrics and more recently in Aboriginal health.
So it sounds to me a bit like, having read up on this, that you really need to be a sort of Swiss Army knife. You need to have all the tools for the job. And is this then just because sometimes the distances are so big to the nearest hospital, or are there other reasons for it as well?
Sure. So obviously distance is an important thing, but in a lot of communities there might be other constraints, other place-based constraints that prevent patients getting the clinical or getting conventional treatment. So even quite close to Adelaide, people might not be in a position where they want to travel into the city, or they might have carer responsibilities or cultural responsibilities that mean that unless care is available to them very close to home, they choose not to access that. Also, costs for travel to relocate for some treatments are quite challenging for patients. So sometimes even if they would like a particular service, if it's not available close to home, they're not able to access it. And so we need to think about how can we adapt conventional treatment in order to provide access to something reasonable rather than have them have no access at all to care.
That makes sense. So it's about also bringing the treatment to where it's needed, but I also assume you're constrained in a way that you can't go door to door offering treatment. So where do you find that, or how do you find that balance?
Sure, and look, I think it's an individual thing how far people are prepared to stretch themselves, and it depends on a number of things. So if somebody said to me, Lucie, can you please do brain surgery or can you please provide an anaesthetic, I would say no, because it is well beyond the scope of my practice. I don't have the skills to be able to offer that to somebody in any way safely. But also, it would not be a reasonable request from a patient. While if, for example, somebody said to me, look, I want to stay close to my family at a time when I was, had a terminal illness, then even though palliative care is perhaps not something that I'd feel comfortable doing routinely, with support, so by ringing a palliative care specialist in the city, for example, and getting some additional knowledge and supports, and after a very careful conversation with a patient about what I was able to provide and what I wasn't able to provide, I could lean into the challenge of providing somebody with palliative care quite close to home. So how do we make those decisions? We've been working on a way that people can structure the process of making these decisions and the way they have conversations with team members and with patients, and then a way of documenting that. And so, for example, if in the case that I described of a person requesting palliative care, if conventional therapy was that they should, come up to the hospital in my town and then remain as an inpatient in the hospital in order to get care. But they said, oh, no, I live on the farm and, we've got animals to tend for and I want to be able to see my grandchildren and children each on a daily basis, so I don't want to come into hospital, so there's an obstacle to that conventional treatment. And so they were unable to accommodate the initial proposal. I could review my options and say, okay, well, what kind of facilities could be provided by me and perhaps extended team members, the palliative care nurse and telehealth specialist from the city or someone who might visit our town. And we could then think about what is the critical preparation that we need in order to make it possible to have care provided for this patient at home. Do we need infusion pumps? Is there, need for suction or oxygen? What sort of resources are available? Or, what could we adapt in order to provide access to those things? What are the risks that are associated with doing this at home? Who are the team members that would need to engage in that, and have we had the appropriate conversations with those team members, and are there also external supports that we could draw on that would enable treatment at home to be possible? And then having had those conversations, we can document or work out who is in agreement with this plan to do something beyond what would be routinely done by me in the context in which I work. And then having agreed on that, we also can think about what are our exit strategies. So are there particular things that might happen in the course of somebody passing away and having palliative care at home that would mean that we had some non-negotiables and we would need to move that person to the hospital. And that way we can use that mnemonic of courage, so conventional treatment, O, obstacles to care, U, we're unable to provide routine care, R, or RCTS, our treatment risks, critical preparation, team and supports, and then an agreement, AG for the courage mnemonic agreement, and then finally what are our exit strategies. So this is a way of thinking about, when you're thinking, oh, I'm not really feeling comfortable, I've only, as you said at the beginning of this podcast, I've only done this once or twice before and it was a long time ago, but how can I lean into this and provide a patient with what is needed?
That sounds like incredibly good healthcare for that patient, for their family, but it requires a lot of flexibility from you, from the healthcare team, also from the specialists in the hospital who might play a very different role than they traditionally do by just, admitting a patient and seeing them. Do you maybe have some insights? What works well? What can we learn from this approach? What are still the challenges of making this work?
Sure. So firstly, one of the things that we've recognised that are really important in this, to provide care with courage is adaptive expertise. So you need to have good functioning within their health service and know what is the capacity of that health service, what resources are available, both in terms of pieces of equipment and people and what their skills are, and be able to work quite effectively in that environment. But then to have adaptive expertise where you can take the basics and apply them to a different problem. So, we think about, airway, breathing, circulation, our ABCs, and, how can we just pick that up and then utilise it in a different way, in a different context. Then the second thing that we've learnt that is really required in order to work with clinical courage is to have a really strong sense of community, so to understand your community, what are the norms and the expectations of the community, and how do you belong? So belonging to a community helps, if you know the community and they know you, it builds trust and it enables you to be honest about the risk that you're taking on behalf of a patient. When you're saying, okay, well, the best evidence is for you to have palliative care within the hospital environment, but we can make do in your home environment and meet that place-based need for you. But these are the limitations and the risks that you and I together are taking on if we undertake this alternate care. And that way, the conversation enables not only the trust between the two of you, because your patient needs to trust that you're doing the best for them, but things can go wrong. You need to trust that they really genuinely understand and recognise the limitations of this care, and it's the best, choice for them. And their family and community need to understand that you're acting at the request of the patient rather than, doing something that's not conventional for some other intent. So this is very patient-centred, but it's more than patient-centred. It's actually saying, I as a clinician will, step towards your desired care and away from conventional care in order to provide as much as we can within the constraints of this context.
And that also requires vulnerability. When I hear it, it's quite the step away from the doctor knows it all, the doctor can fix it all, also being able to admit your skills that you're good with, but maybe the skills you can't provide to a community. What is in it for a doctor to be so vulnerable? And also I assume you will have challenges with insurance policies and other sort of guidelines that you don't play by.
Sure, yeah. And look, I think these are things that are still being explored in the research. I think that we have evidence of stories where people, rural generalists, have pushed themselves outside their usual scope of practice to provide care for patients and have been criticised. Often they're criticised by people that don't understand the context and see their behaviour as being, cowboy behaviour. But I would argue that cowboys either don't understand risk or don't respect it. And that's not what I see in my colleagues, my rural generalist colleagues, that have very bravely chosen to walk a path less travelled with less resources and do the best they can to manage the care of patients within their communities.
And I assume they are happy that they walked this path.
Sure. So one of the research projects that we did was to develop a survey that helped us to describe or quantify how much clinical courage people had. And what we found is that when people scored higher on the clinical courage questionnaire, they were more likely to have been in a rural area for a long period of time, and they were more likely to say that they intended to stay for longer. So we know that clinical courage grows over time, and also that it perpetuates interest in remaining in a community and serving that community. Importantly, we also looked at other surveys, including anxiety and depression rating scales and burnout scales, and found that the amount or the score in clinical courage was not correlated with those things. So this is a process of vulnerability, but also of sharing risk. And so it's not a process where we're increasing the risk of burnout or anxiety and depression. Interestingly, there was a weak correlation with fulfilment, professional fulfilment. So we think that if anything, it's likely that it might be protective rather than detrimental for a rural generalist to work with clinical courage.
That's wonderful to hear, because when we talked about going outside of your comfort zone, widening your scope, being clinically courageous, I was thinking, actually that's extra effort and you might be more likely to be burned out or to move to a different field in medicine. So that's wonderful to hear. Do you have any idea why that is? Is it just living in those communities, serving the community? Is it about the interaction with the patients, or the interaction or the type of interaction you have with your colleagues?
I think why is probably too strong a word for the conservative researcher in me to feel that I can answer. But again, from our qualitative research, we have been able to show that relationships are very important in clinical courage. So certainly the relationship with patients and the community more generally is really important. So we think about this as a relationship capital. If you know people and people know you, you've got an opportunity to, or license, if you like, to stretch your scope and be seen as that being a responsible thing to do. The relationship within your team is so important. So we've seen rural communities where the culture of that medical and healthcare team is risk averse And so a new person coming into that team who was to enact clinical courage would probably be seen with anxiety and distress, and would probably feel they needed to kind of, draw back on how patient-focused they were. While there's other communities where there's very much a culture of service and a culture of wanting to contribute as much as they can to their local community. So the relationships within the local team are really important. And then probably something that we have not focused on enough, but is clear in the literature, is the importance of relationships with external parties that understand and value contextual expertise. So I'm not a palliative care physician, but a palliative care physician, there's no palliative care physician in my town, but a palliative care physician that is in the city, if they value my contextual expertise about my town and the services that are available, and I value their discipline expertise, that relationship can be mutually beneficial for providing access to care for patients in my community.
So I initially thought clinical courage was then an individual act, but it sounds more like a community act, that you are clinically courageous together. And is this also how you then learn how to be clinically courageous? I'm also asking, as a student,
Sure.
How do I navigate the tension between I don't know something yet and I should be uncomfortable and I should broaden my scope, but I also don't want to become that cowboy?
Sure, and look, the research that we did last year that's still to be published was looking not at students but at Australian College of Rural and Remote Medicine registrars, so people who do a 4-year postgraduate vocational training to become a rural generalist. And we were looking to see what or how that group developed their clinical courage. And there's a lot going on for registrars, as there are for students. And one of the things for us to remember is that, within the culture of medicine generally, you're trying to purport to those that, or demonstrate to those that assess you, that you are competent and that you know and understand your limitations. And so that almost works, as a tension, where, clinical courage is saying, can't you push a bit further? So registrars certainly experience that feeling of stretching themselves, just trying to develop the broad scope of skills that they need. So beyond, before they even get to the scope of practice for that context, they're just trying to meet all the curriculum requirements needed to become a rural generalist. They're also moving often from episodic care, which is how we usually learn medicine about, this person presents with shortness of breath and then, 3 months later they present with palpitations, to the continuity of care that happens when you are based in one community and see people over a period of time, particularly in primary care, where, if you like, your mistakes come back to haunt you or at least see you again. And then, as well as that, the other really challenging thing I think that registrars in a rural community are learning is how to navigate the dual role of being a member of the community, where you share of yourself and, you play basketball on Tuesdays and you sing in the choir on Thursday nights and, you go to the community events. And the necessity to hold yourself back a little in order to be able to have a clinical relationship with someone where you're examining them intimately, for example, and needing to kind of have this othering in a relationship. So what we found is that registrars need to have conversations with their supervisors about when their supervisors felt that they were stretching themselves and how they managed that. They need to have conversations about how to manage boundaries so that they're not asked about the skin spot in the supermarket, and how to share of themselves and yet separate themselves. And then they need to have modelled and learn how to have the vulnerable conversations. And I mean that by perhaps the difference between a learner and a more experienced rural generalist is a learner might say, oh, I don't know how to do palliative care. And that sounds like it's a shortcoming and a vulnerability in the learner's preparation, rather than a rural generalist describing that, palliative care is out of my scope currently, and it's a long time since I've done any of this work. So I can define for you the limits of my current expertise, and you're asking me to stretch outside of that. And so we need to think about how we together could do that safely. So there's a confidence in the discussion, and yet there's still a vulnerability.
So there's confidence with retrospect. And as a student, I think quite or learner, it's quite often the feeling, fake it till you make it, or, depending on your context, being allowed to be vulnerable or not. So I think we can take something away from that.
Can I just jump on the fake it till you make it for me? I like to ask people not to use that term and instead use the term of benign deception. I feel like fake it till you make it still is too self-critical. Wow, what we're wanting people to do is to say, all right, you're asking me to put on this new costume, this new piece of clothing, and act in this new role, to act in a palliative care in the home role, and the coat is a bit big and it's a bit prickly and it doesn't feel like it fits me yet, and yet with time I will fit it.
Thank you for the feedback. So you also mentioned being in those communities, but also needing some professional distance. Is this something everyone finds out for themselves over time? What a healthy professional distance to a patient is whilst immersing themselves in the community? Or is there also guidelines or something the research shows that helps us to determine whether we should move closer to the patient or actually keep some distance?
One of the lovely papers that I've read describes how when you have two juxtapositions, there's not necessarily a boundary, but there is a gradient from one to the other. And the position that you want to be, or you want the boundary to be that you don't want to step over, is fluid, and it's negotiable. So it might be that, for example, you are happy to see a person who is in your netball team as within the primary care environment to manage a skin spot or a transient acute illness, but that you say, look, actually, I'm not really comfortable to do an intimate examination because we have this role. So where initially, when you didn't know them and they weren't on the same netball team, it was quite appropriate that they come to see you for this. Then their position changed, and over time you need to renegotiate that boundary. And so there are some tools that we can learn, but I don't think it's well enough taught. Certainly for most medical students, what we learn is that you shouldn't have dual relationships with patients, and of course in small communities that's highly inappropriate. Why should a person in town not be able to access care if I'm the only person that's available to provide that, or even if I'm their preferred provider. There's someone else, but I'm their preferred provider. But those, what it means in terms of what we can and cannot do needs to be negotiated. Some examples from my own experience is I have delivered the babies of some of my closest friends, but we needed to sit down and say, you know, this could go terribly wrong. Something might happen and to your baby or to you, which makes you very angry with me. And I'm happy to contribute to your care and to be the doctor in charge of the birth of your child. But what I'm saying I'm happy to do is to risk that you might be angry with me and not want to see me again socially if things go wrong. Are you aware that that's what we're risking, and are you happy with that risk? And if together we are, we can progress. And if not, we need to find an alternative arrangement.
So it's not possible to have a clear cut between friendship and doctor, which sort of makes sense, yes.
Yeah.
So you already talked a little bit about community, being immersed in a community, and also for students that seems to be quite important because you've done research on longitudinal integrated clerkships. Maybe you could quickly share the definition, what it is, and what the benefits are.
So basically this is when you are immersed in an environment like a rural practice where you learn all of your the disciplines in your curriculum at the same time. So rather than doing a block in medicine, a block in surgery and a block in general practice, you go to work with the rural generalist, meet in the morning to go to the hospital and do a round, and then go to the primary care environment and see patients in the general practice. And then if somebody needs admitting, you'd follow them back up to the hospital and do the admissions, so that the curriculum walks through the door, if you like, and you learn all of the scope that you need for your exams at the same time.
And you still learn enough. You will still be able to pass your exam. You don't need those blocks in the clinic, hopping from department to department.
Sure. So if you think about how you did your final year at high school, you didn't do 2 months of maths and then 2 months of French and then 2 months of science. You actually learnt a little bit of every one of those things each week and had exams at the end of the year, you know, that were discipline-based, but on each year. And so we know that there's cognitive things like interleaving, learning one thing and then another and weaving them together. And also we know that being reminded over a period of time increases your likelihood to remember things. And there's work done now across many longitudinal integrated placements across the world that have demonstrated that students do at least as well, and occasionally they do better, consistently better, in their exams when they've had the opportunity not to forget surgery because that was the first placement in the year.
Yeah. And how long would such an internship or clerkship typically be?
So most for 1 semester or for 2 semesters. So in our program, we run a full year of longitudinal integrated immersion in rural areas, but for many schools across the world, it's between a semester and a full year.
So I did block rotations, so 4 to 5 weeks at a time in one of those departments you mentioned. And it sometimes feels a bit like speed dating, going very fast from department to department. But then again, some departments you love, some you like less. So then it's also nice to be able to move on. I can also imagine if you sit somewhere for a year, it can be really transformative and beautiful, but it could also be something you don't thoroughly enjoy. Is that a thing that happens, or?
Of course.
Yeah.
It's only human nature, and it's everything from, in our program we bring people from Adelaide to rural areas, the closest of which is only half an hour's drive, but the furthest away, Ceduna, is about 10 or 11 hours drive. It's about, so a long way away. And so you can imagine it might be homesickness, or it might be that the relationship between the supervisor and the student break down. All sorts of things can happen. It happens surprisingly rarely. And in my time working with longitudinal rural programs, which has been over 20 years, I couldn't even find a handful of students that we've had to move from their placement. Sometimes in a practice where there's 2 or 3 supervisors, I'll have a preference for 2 of them and not for 1 of them or whatever. But certainly it's very, very rare that the circumstances are so bad that we've had to, intervene.
But I think that's the same in the hospital. You always have staff in a department that you get along with super well and others that you just get along with less well. So is there any other benefits aside from what you learn from a medical content perspective? So the exam, you pass, you might even do better on the exam. But is there other benefits of having students in those communities for longer times?
So there's probably benefits. The other benefit for students is that we know that when students are present in a community for a longer period of time, they build up their own support networks, their peers, but also their supervisors and community members. And the wellbeing of students in longitudinal integrated placement seems to be better than the wellbeing of students on block rotation. And that's really important because we know that wellbeing for medical students is, quite a precarious thing, that there are a large number of medical students who, that suffer from, the huge demands that we put on students during medical school. I think there are other benefits too. Certainly, my PhD looked at the impact of students on the supervisors, and there was a very different kind of sense of ownership and mentorship that developed between supervisors who had students for a full year. They were very much more invested in the students' exam results and how they went. When they graduated, they were keen to celebrate that, and they became, for many supervisors, they have long-term friendships with people that become their peers. So that's really of value, I think. And it also increases the sense of being a community of practice between rural GPs who are all engaged in supervising the students. So, where sometimes if there's 2 GP practices in one town, they would be seen as being competitors. Having students in common brings them together and enables them to feel much more like a collective team.
That sounds great. That sounds wonderful to be able to be that bridge between teams. And it also sounds like, you develop more of a relationship alongside each other, whereas in a hospital with block rotations, it might feel more like a production, like a factory, right? You need to move on and produce graduates rather than getting to know them as a person. You mentioned building up a peer network. Is this then also with the doctor supervising you, or how does that look like, that peer network that students build on these longer placements?
Sure. So, I think that spending a full year with a small number of students, in a far, far away place creates lifetime friendships. And we've got, many examples of people who describe that their closest friends from their medical school days were the group that they, relocated to a rural community together and, spent the year having, a grand, sometimes challenging, but a grand adventure. But I think also just because of small numbers, there's often a vertical integration of friendships. So the junior doctors become good friends with the students, and sometimes in some of our communities the junior doctors are rotating but the students are not. So when the new bunch of junior doctors arrive and they're looking to, navigate the health system but also the town, which pub do you go to for the quiz night, and which gym should I join and things, it's the students that provide that social know-how that enables the junior doctors to engage, and then they develop friendships, and that can influence networks and influence the opportunity for mentorship and just knowing what's coming up in the exam, or how do I apply for my internship, or is it a good place to go to to apply for a job in this place or that place.
It's great to see that then also students' knowledge is appreciated and actually useful for other healthcare professionals. Great to hear. So is then there also an increase in people wanting to practice rural medicine once they've lived in the community? Because I can imagine if you make friends there, if you connect to doctors, you're also more likely to stay in those communities or return to them later on?
Sure. So, even recognising that there's a self-selection bias because we're, students are choosing to come to our program, there's certainly good evidence that the likelihood of alumni who've spent a year living and working in rural communities, those students on graduation and into their future are more likely to work in rural and remote areas. They're also more likely to work in general practice, which is another really important part of our health system that currently is undersubscribed. So, we're making the health professionals the doctors that our communities need through the longitudinal integration placements.
So if there's someone listening still torn between working in a big centre in a city versus going into maybe rural medicine or becoming a GP in a remote area, do you have any advice for them on how to figure this out?
Oh, look, it's tricky because I'm very biased. Somebody said to me once that they questioned the wisdom of jumping into rural medicine, boots and all, where the only wisdom I question is the boots. I think bare feet is a better option.
Bare feet, all right. Wonderful. I learned a lot about rural medicine, what we can learn from it. It sounds like a wonderful place to do an internship or clerkship. Is there anything you would like to leave students or educators that listen with?
Certainly, I think that the advantage of rural communities and rural health services is the opportunity for us to create meaningful relationships. And that's not impossible, but much more challenging in large systems where there's so many moving pieces. It builds on the opportunity for us to learn, when we think about the emotional cues that our learning, that it engages our learning, but it also makes important meaning, which is such an important part of your own wellbeing. So I would encourage everybody to consider their opportunities and take them.
Thank you very much. I hope they consider it. Thank you for your time.
Thanks very much. It was lovely to be here today.